welcome everybody. It's really a pleasure to be with you today, and on behalf of all the faculty present here that you can see, a distinguished faculty, we will be discussing today an important topic, which is what should we do when we see a patient with an unplanned R1 resection? What should be the strategy? And we will have a discussion based on 3 different presentations. The first presentation is a consistent surgical approach by Francois Gouin. Second presentation will be given by Professor Shintaro, Iwata, and Professor Nakamura on individualized surgical approach. And Dr. Andrew Bishop will provide the view of radiation oncologist. If each presentation will be conducted during about 20 minutes, we'll try to keep the questions at the end, but if there are burning questions in between, you can raise your hand. We'll try to do our best. Get ready for the discussion, because this is going to be very challenging. There is no black and white answer. There is no truth. What we need to do is discuss and try to come up with if not a consensus, at least a feeling of what we should do together. And without further ado, again, thanks for the organizers. Thanks particularly to Bruno, who have been very active in organizing this. And I will hand over to Francois Gouin for the first presentation on consistent surgical approach in front of an R1 resection, which is unplanned. Francois?
Thank you very much, Bruno, for this very kind invitation. And thank you, Jean-Yves. Thank you, all my co-speakers. And it's a great honor, and but also a hard task to defend a point of view of this very controversial topic, what to do after an unplanned resection out of a sarcoma center. Here are my links of interest. So the question is, should we reoperate all the patients after unplanned surgery out of a sarcoma center, what we commonly call a whoops procedure? One thing is sure, it's that the abundance of the literature on the subjects that probably reflect the amount of uncertainties on that topic. The other thing that is sure that no definitive answer to this question, sure. But in our daily practice, we need a frame to make a decision. That's why, without any suspense, the answer of this question for me and for us in our medical tumor board is that, yes, at least we have to consider reoperation for all cases after unplanned surgery out of sarcoma center. This answer is mainly based on the literature analysis and in our experience in the French NetSarc+ national database network. As a preamble, I have to say that when you see the literature, there is very low level of evidence to have a good answer to this question. And except the 3 papers that relies on direct argument, most of the papers rely on indirect arguments to support the reoperation option. The first group of papers in the literature are guidelines. All the guidelines saying reoperation is the recommendation after unplanned for ESMO, for NCCN, UK guidelines. And there is no discussion for guidelines. And if you remember that adherence to recommendation improves overall survival and local control, it could be an argument for a systematic reoperation. The second group of papers rely on the fact that when we operate patients, you find a lot of cases, a residual tumor in the bed of surgical resection. That's very common, of course, and that's very important to see that the rate of residual tumor range from 31 to 72%. That's a very huge range of presence or absence of residual tumor, and that can have some implications in the future decision. The next group of papers that supports systematic reoperation is a very common association with local recurrence and a lower overall survival or disease-specific survival. This recent paper from Italy its literature analysis reports that most of these papers show that local recurrence is associated with a lower overall survival. These things have been reported for more than 25 years ago. David Bio reported it more than 10 years ago. But I consider that if it's an observation, that's not mean that there is a causal link between local recurrence and overall survival. That's not a direct argument to resect these patients after unplanned operation. But most of the paper can observe that this link between local recurrence and overall survival. The next group of papers in the literature is also an indirect argument for the resection. That's the association between microscopic residual tumor with a lower overall survival and disease-specific survival when these patients have been reoperated. You can find a lot of papers that report these results, but not all. You see at the bottom of the diap here and in the previous diap some box that reflects the patients were included in diverse papers. On the left side, that the patients that directly addressed to a referred center, and the three boxes on the right are patients operated first out of a reference center, and these patients are reoperated sometimes, not reoperated sometimes after referral, or never referred, and we don't know what the fate and the outcome, the oncologic outcome of these patients. Why that? Because most of the papers rely on the study of patients referred and reoperated, and very few papers look at the patients referred, not reoperated, or no referred to centers. That's an important bias on the literature. So even that, microscopic residual tumor is very often associated with a lower overall survival, but like for local recurrence, that doesn't mean that there is a causal link between these two things. The next group of papers that support the reoperation are the papers who find a very good outcome, oncologic outcome, compared to the patients firstly operated within a reference center. And in these papers, they compare patients operated out of centers, reoperated, with patients firstly operated in a reference center. And most of these papers show that after reoperation, the oncologic outcome in terms of overall survival, but also metastatic free survival, is as good or even sometimes better than the patients firstly operated. And that's also an indirect argument for reoperation, but only indirect argument, I consider that, because we don't know what the fate of the patients not reoperated yet. The next group, and there are the three papers with direct arguments, that's best papers, I think, to support systematic reversion. The first one is the Zagar paper, because in this paper, the authors look not only at the patients referred and reoperated, but also at the patients referred and not reoperated. And they don't compare outpatients with inpatients, but only the population of interest, that means unplanned outpatients, operated or not. And in this study, they compare 666 patients referred after complete microscopic resection, and 44% have been reoperated on the basis of expert discussion, and always receive radiotherapy. And clearly, in this paper, reoperation in this case is associated with a better local recurrence. That everybody knows that, but also disease-specific survival and overall survival in case of positive microscopic or unknown margins. I think this paper is a very good one to support the systematic reoperation. The next one is a paper of Nakamura, here present, and it's this paper of patients also coming only from out centers and patients reoperated compared with patients not reoperated from the Japan registry. And in this case, we have 154 patients immediately reoperated and 20 not reoperated. And that's a direct comparison of reoperated patients and not reoperated patients. And again, they found that there is a high rate of reconstruction, that's sure, but the 5 years local recurrence free survival and 5 years metastatic free survival is better, significantly better after re-excision. That's also a very, very good argument for reoperation. The next one is a paper from our French group. And in this paper, patients operated out of a center, reoperated and compared with not reoperated patients. And also because of the organization, the exhaustivity of the organization in France, we can have a look at some patients who have never referred to reference centers, but we have some information about their outcome. And in this case, we have 1,284 patients with sarcoma of limb and trunk wall. And what we can see that after adjustment, overall survival and distant recurrent survival is improved after re-excision, along with the age of the patient, the size, and the grade, which are negative factor on these patients. So in this study, re-excision is an independent favorable prognostic factor for overall survival in a good population for that. And when we look at all the subgroup, we can see that this improvement occur whatever is the depth of the tumor, whatever is the grade of the tumor, the size of the tumor. Unfortunately, there is two small groups to compare, some groups like small, low grade and superficial tumor. It would be very interesting to know for this kind of tumors, and also for the very urgent delft and high-grade tumors. So in the macro analysis, we see that re-excision is a positive action to improve overall survival. We have completed this study, but it's unpublished data at this time. The manuscript is in preparation. We also compared in this study re-excision in terms of metastasis-free survival. And we found exactly the same results, that re-excision is an independent factor of improvement of overall survival, not overall metastasis-free survival in this population of patients operated out of a reference center. And finally, I can conclude without have a word about this paper from our group published by Decanter 3 years before the last paper, because this paper didn't find any link between reoperation and the overall survival. And probably one of the explanation, it's not exactly the same patient, probably the explanation is because they included in this study a lot of patients we could hide the benefic effect of re-excision. I mean, there is 68 patients with R0 excision, and there is also very low-grade tumor like WD, LPS. We have which have very good prognosis tumor, and the absence of link between reoperation and overall survival in this study might be due by the lack of power because of the small samples in this study. And finally, I would say that the question is probably very complex of benefit effect re-excision, because like some of others, we didn't find, that's not already published, we didn't find any link between the quality of margins and the overall survival or metastatic free survival. Like most of the authors, we said, don't reoperate because we don't have any link between the quality of margins and the outcome. But if you have, in fact, the problem is that we have paradox, the paradox of the absence of link between the margins and the benefit effect of excision. Where is the problem? That's a really point for us. I don't have the answer, but I think that's a point to be explored. Maybe the reoperation could have a positive act, it can act itself, but probably reoperation also means a lot of things that we not observe, that we not include in our statistical models, like more patients are referred when they are reoperated. The referral time between the operation and the reoperation is shortly when the patient is reoperated. Maybe patients reoperated have more discussed in a multidisciplinary tumor board, and we know that have a positive effect on the outcome. And probably they have different follow-up modalities. Probably the rate of radiotherapy and chemotherapy of patient properties is not the same than the other patients. And maybe there is other biological effect. I mean that reoperation is not only, probably have not only an effect on the margins and on the tumor in the bed, but a lot of other things can be moved with the reoperation. So, in conclusion, the answer to the question, should we reoperate all patients after unplanned surgery? For us, it's yes. At least we have to consider reoperation in all cases because of the indirect action probably of reoperation. I totally agree that the final decision relies on patient condition and anatomical site, but we have to give the message of reoperation, because reoperation means the patients will be referred. The patient will be referred shortly because a lot of other things with along with reoperation. And that's realized, and you saw that most of the papers support indirectly this option, and 3 papers, very interesting papers, support directly the positive effect of reoperation. Because also I didn't have time for that, but the literature for wait-and-see policy is very questionable and poor also. And I can see that not all subgroups benefit from reoperation, but indeed consider it and conduct further study to identify the relevant subgroups to benefit from reoperation. Thank you for your attention, and we'll see for the discussion.
Thank you. Thank you very much, Francois, for this quite exhaustive presentation of the current state of the literature and to providing your vision on reoperation in specific case. I don't see question at this stage, and because of that, I would suggest that we move immediately to the next presentation by Dr. Nakamura. Thank you very much for being here. We know that it's quite late for you, and we are very interested to hear your presentation on a more balanced view on reoperation based on your paper and your different works. Professor Nakamura.
Thank you for giving me the opportunity to present my study tonight. So tonight, I present the current situation on unplanned excision in Japan and suggest the new study including R0 and R1 resection. First, please introduce my town. Our city is the center of the Japan center. We have a ninja village. It's very traditional village in my town, and we can become a ninja. This is my son. We can become a ninja in my town, and we have a very traditional shrines. So it's very countryside, but a very beautiful town. So I stayed ROH Birmingham for 1 year, about 10 years ago. I experienced a Diamond Jubilee and the London Olympic Games. I'm very happy to work with famous consultants, with especially Mr. Grimer and Mr. Carter before their retirement. And Shintaro and I visited MD Anderson Cancer Center as a traveling fellowship. Professor Ruiz and their colleagues gave us the best of hospitality. And Shintaro and I have a friendship more than 10 years. So, okay, I started my topic. Why do I have interested in unplanned excision? First, I always feel the difficulty of MRI after unplanned excision, especially for skull-like mass. Second, it's very hard to define the surgical margin. Sometimes I experience a local recurrence outside the surgical field, even if there was no residual tumor. Third, reconstruction may be necessary, and it should be additional invasive procedure to the patients. So I think how to reduce the frequency of unplanned excision. Before education and communication with surgeons and medical students, I need the real-world data in Japan. Electronic version of bone and soft tissue tumor registry has been started since 2006. Japanese Orthopedic Association approved the use of this data in 2013, and I applied for use to analyze the real-world data of unplanned excision in Japan. Between 2006 and 2016, about 8,700 patients with trunk and extremity soft tissue sarcoma were registered. The quality of data is not perfect, so I checked all cases by my eyes if the case completely fit unplanned excision. The average frequency of unplanned excision was 11%. The frequency looked like a little bit decreasing for 11 years. The small and superficial sarcoma was often rejected as unplanned excision in all types of soft tissue sarcoma. For example, 25.7% of small superficial UPS was rejected as unplanned excision, while 3.4% for large and deep UPS. The prognosis was similar between planned and unplanned excision, but I think the additional statistical power should be necessary. So I did a comparative study using this registry data. I collected about 4,500 patients with extremity sarcoma from registry data. I did the propensity score matching concerning confirmed variables such as age, sex, height, and size. Finally, I compared the 355 cases with planned and unplanned excisions. After matching, there was no difference on background between planned excision and unplanned excision and re-excision group. So in Japan, the size of the tumor is relatively small compared to the European patient who received the unplanned excision. So after matching between two groups, there was no difference of survival, and local recurrence rate was also no difference between two groups. But reconstruction using skin graft and flap may be necessary in unplanned excision and re-excision group. I studied small sarcoma with R1 and R2 resection at unplanned excision. This data, unplanned excision and wait and see policy looks like the high rate of metastasis and local recurrence, but only 20 patients and very few, so we need a lot of study to validate it. I show the summary of the study. Frequency of unplanned excision in Japan was 11%. Survival and local control after unplanned excision and re-excision were similar to unplanned excision. But reconstruction should be more considered in unplanned excision and re-excision group. And have we known all of unplanned excision? We have known the re-excision with wide margin is recommended, but the timing of re-excision has not been established. So I wonder if prompt re-excision is really most promising treatment after unplanned excision, especially for R0 and R1 status. We believe the prompt re-excision contribute to outcome after unplanned excision in spite of some risks such as the difficulty of surgical margin setting, frequent reconstruction requirements, and cost. But is it true? I'm very surprised at the study from French Sarcoma group in 2021. They showed what I want to do. Many attendees should know this interesting paper. They suggest a wait and see after unplanned excision in selected patients. Of course, I know that a lot of studies recommended re-excision. So I suggest a new project in Japan Clinical Oncology Group, JCOG. It's under consideration. I would like to do the randomized study between prompt re-excision and wait and see in selected patient with R0 and R1 resection. But I have still some concerns, such as surgical margin evaluation. Does it include all subtype of STS? Or can we permit adjuvant radiotherapy? Or can we register sufficient number only in Japan? Or we need to international collaborations? So we have a lot of concerns before the study. So last year, I have studied prospective observational study in Japan to know recent real practice treatment for unplanned excision in Japan. 33 hospitals are attending now. I collect the data which cannot include the registry system, such as the date of unplanned excision and evaluation of surgical margin at unplanned excision. The recent number of patients with unplanned excision may be estimated by present observational study. Thank you for your kind attention. Thank you.
Thank you very much for this very clear presentation and impressive registry that you have constructed. I think this is full of information and certainly food for thought for the future discussion. I see no questions arising, and therefore I suggest we move immediately to the last presenter, Dr. Andrew Bishop. Thank you very much for being with us today. So you will cover the topic of not re-excision, but the use of radiotherapy in this context. Please tell us your thoughts.
Yes, thank you very much for having me participate in today's webinar. Let me share my screen. All right, so thank you for those first two great talks on the role of re-excision. Hopefully after these next 20 minutes, I can give a little bit of insight about how to potentially incorporate the role of radiation therapy into these complex scenarios. I'm going to both review the data and also use a couple of cases to highlight how the radiation oncologist might think about the unplanned excision. So let's start with this vignette. This was a 33-year-old male who presented with an enlarging tender mass in the right buttock. Eventually, a workup revealed a nearly 5-centimeter tumor or 5-centimeter lesion that was, you can see on the right here, viewed as a kind of a heterogeneous mass, kind of cystic in nature on T2 sequencing with a fairly well-defined margins on the lava sequences. This was suspected to be a perianal abscess associated with a fistula. So he was taken to the OR for an EUA and an IND with seton placement, which for those of us, for those radiation oncologists in the group that didn't know what a seton drain was, it essentially involves sticking a tube between the abscess and the anal canal to try to keep that fistula tract open and prevent the reformation of that abscess. At the time of that IND, the large clot was removed and sent for outside pathology, with preliminary pathology revealing a suspected myeloid sarcoma, which brought him to MD Anderson. On review of the pathology, this turned out to be an EWSR1 rearranged extraskeletal Ewing sarcoma with morphology revealing a fragmented hemorrhagic cystic tumor with round cells. Staging was negative for metastatic disease and no residual tumor, so he went on to receive chemotherapy with VAI. And then came the question of local therapy. Does he need more surgery? Does he need surgery and radiation alone, or should we observe him? And we'll come back to that question here in a few minutes. So that leads us to the question of what is the role of radiation in patients who undergo an unplanned sarcoma excision. There's really two ways to incorporate radiation therapy if we're not doing observation. The first is in combination with surgery, and the second is using a radiation alone approach after that unplanned excision. The ASTRO group recently published these consensus guidelines on the management of soft tissue sarcomas to try to guide radiation oncologists on how to think about the management of soft tissue sarcomas. And that group did address how to think about the unplanned excision. You can see on the first line, the consensus was that following an unplanned excision, that an oncologic re-excision is recommended when feasible. And how do we incorporate radiation into that? When an oncologic resection is planned, the recommendation or the consensus was that radiation is indicated, preferably in the preoperative setting. And when a re-excision is not feasible, that postoperative radiation therapy is recommended. So if we look at the data at which these consensus guidelines were based on, you can see that they were primarily based on the historical large randomized trials that really established radiation therapy to be important in the treatment of these patients. But that's a different patient population, because that's patients who undergo a wide local excision and not just an unplanned excision. So if we look at the data that are available to us that are pertinent to this patient population following an unplanned excision, the data are a little bit all over the place and not quite as strong. So these 5 studies are patients who underwent an unplanned excision followed by radiation therapy alone. And you can see that they were published over the course of the last 2 decades and often kind of subsets of a larger cohort. But the bottom line is that overall radiation seemed to be associated with improved local control in these studies, with a local control ranging between around 80 to 90% following an unplanned excision and radiation therapy alone. The alternative is when we incorporate radiation with re-excision. These 3 studies looked at that question using preoperative radiation therapy followed by re-excision. And again, overall, that combined modality approach seemed to have favorable outcomes with a local control rate of around 95%. So in general, I don't think that the role of radiation therapy is clearly defined in these patients following an unplanned excision. We do largely extrapolate from the randomized trials, which is a different surgical procedure. There are some retrospective data, which we just briefly looked at, that seem to show favorable outcomes with the use of radiation therapy. So in general, I think that when treatment is recommended, radiation therapy should be considered part of the management following that unplanned excision. There are a number of questions I think that are really important to think about in that multidisciplinary discussion. And these are some of the questions that I ask myself when I have a patient in this scenario sitting in front of me. What are the margins following that unplanned excision, and what does the post-operative imaging show? Because that relates, that correlates with local control, how I think about my radiation dose, how I think about the radiation-related toxicity. What is the histology? What is the biology? What is the location of the tumor? And would I have recommended a combined modality approach had that patient presented to me in the de novo setting without undergoing an unplanned excision? Importantly, what is my surgeon recommending? What are the implications of a repeat-wide local excision at this time? Is there even more margin to take? What are the implications of a local relapse? What does a salvage surgery look like? And is that morbid? And what is the disease biology? And also importantly, what are the patient preferences? Do they want more surgery? And how do they think about function and quality of life? And how do they incorporate the radiation-related toxicities into that decision-making process? So after an unplanned excision, I think patients crudely can be put into these 3 buckets. Thinking about margin status and the imaging findings following that unplanned excision. In scenario 1, we have patients who undergo an unplanned excision with a negative margin excision and no disease on postoperative imaging. In those cases, there's likely not a role for additional surgery, and we probably should be thinking about postoperative radiation therapy. These data on the right represent the local control following an unplanned excision with negative margins that received postoperative radiation. And you can see that the local control, while it's marginally lower than it maybe had a patient undergone radiation and re-excision, it's still quite favorable. So this is an example of a case, a 65-year-old female. She presented with a painless, kind of growing, firm lump on the lateral part of her left thigh. She underwent an ultrasound and astutely an MRI before anything was done, which showed this mass here. You can see kind of the tails wrapping along that fascia, superficial to the muscle. So she underwent a surgery, not a wide local excision, but also probably not an excisional biopsy. And the margins were negative with no residual disease on postoperative imaging. So the plan for her, despite not a wide oncologic surgery by a surgical oncologist or orthopedic surgeon, she did have negative margins. So the recommendation was postoperative radiation therapy for her. On the right, you can see the representative radiation plan. The red line, or the red color wash, represents kind of the boost volume. The khaki color wash represents a larger volume. And so this was delivered using a VMAT technique with a simultaneous integrated boost, which was very much intended to model how we historically treated using a 3D technique, with a large volume getting 50 gray, followed by a cone down of an additional 10 gray for a negative margin resection. So the large volume here got 50.4 gray and 28 fractions, with an integrated boost to 59.92, getting us very close to that 60 gray mark. And so this is kind of a way of delivering postoperative radiation therapy with an integrated boost using VMAT. The other scenario, the other easy scenario, is a patient that presents following an unplanned excision with a positive margin and residual gross disease. In that patient, additional surgery is warranted, and the incorporation of radiation therapy is likely warranted. I think that up for debate is the timing of that treatment, but when we treat them, likely we should be thinking about radiation therapy added to surgery. And that's extrapolated from the randomized data of the benefit of adding radiation therapy, and also the increased risk of local recurrence for these patients that undergo an unplanned excision. Radiation therapy likely has additional benefit because their baseline risk of local recurrence is higher. Again, just a vignette demonstrating that type of patient. So this is a patient, again, had a lump in the distal calf that was excised on the outside with pathology demonstrating a 3-centimeter grade 2 myxofibrosarcoma with positive margins. Postoperative imaging was quite suspicious for residual disease with some nodularity notated on the MRI. And so the recommendation for this patient was to undergo preoperative radiation therapy and re-resection. The surgical specimen had a 4-centimeter tumor bed with gross residual disease. Margins were ultimately negative. And so this is an example of a preoperative radiation treatment plan. I'll talk about the dosing here shortly. But one thing that's, I think, important, if there are any radiation oncologists on the line, one of the things that we often think about when we're designing our target is we have this idea that we should be expanding for microscopic extension of disease 3 to 4 centimeters longitudinally and 1.5 centimeters radially. But those guidelines are really intended to guide us when the tumor is deep to the muscle fascia. When tumors are superficial to the fascia, there are no fascial planes to restrict that radial growth. And so these tumors can kind of grow in all directions. So when you're designing your radiation plan, that 3 to 4 centimeter CTV really needs to be in all directions of the subcutaneous tissue, and that 1.5 centimeter kind of radial margin, quote unquote, should be the deep margin, taking into account to ensure that we're giving adequate margins in these subcutaneous tumors. In particular for myxofibrosarcoma, because they are so infiltrative, margins should be designed in a rather generous way, which you can see demonstrated in those represented images on the right. And so the third scenario, the complicated scenario that we're discussing today, what about the patients that have a positive or uncertain margin with no disease on imaging? What do we do about surgery? What do we do about radiation? It's certainly up for debate. We know that these patients are at increased risk of local recurrence, and therefore I do think that there is probably an increased role of combining both radiation and surgery in these patient populations. These are often small superficial tumors, and so they are tumors that one could, had they presented in the de novo presentation, you might have been able to discuss omitting radiation therapy. But after that unplanned excision, after the mucking around, after the seeding of those tissues, I think there's an increased role for radiation, but it certainly requires multidisciplinary discussion. Traditionally, for our group, patients who have undergone a positive margin unplanned excision, we have pretty systematically recommended preoperative radiation therapy followed by re-resection. You can see that the outcomes in using that approach are quite favorable, with local control rates of around 95%. That being said, a recent look at our own data in patients being treated between 2015 and 2020 revealed a pretty low rate of disease in the re-resection specimens, with 67% of patients not having residual disease, and a relatively high wound complication rate of 45%. So, these data have given us pause. In Tumor Board, we certainly discussed these patients with a little bit more granularity, thinking about, how can we perhaps change the outcome here. We still are generally recommending preoperative radiation and re-resection in many cases, but it has become a little bit more of a case-by-case discussion. So after an unplanned R1 resection, what is the role of radiation? It really depends. And it comes back to these questions about histology, biology, local control rates, what the surgeon is recommending, what are the implications of local relapse and patient preference. To highlight a couple of examples, this is a patient who presented with a lump on the lateral part of the right ankle that was presumed to be a benign tumor on imaging. The patient went underwent excision, and the pathology turned out to be a leiomyosarcoma with a positive margin. There was radiographically no residual disease, but there was a lot of discussion about how best to approach this patient. From a surgical standpoint, there was some discussion about the location of this tumor and how an additional surgery would require a free flap, and how that may have some impact on the range of motion at the ankle joint and quality of life. We discussed post-operative radiation therapy, what that looked like for the patient, what the toxicities were for this patient, and what the local control implications of both strategies were. Also importantly, to think about histology-specific recommendations. Leiomyosarcoma in the spectrum of soft tissue sarcomas does tend to be a little bit more of on the radiosensitive side compared to some of the other histologies, which might improve the local control if we did choose a radiation alone approach. And ultimately, what were the patient preferences here? Taking all this into account, she did opt for a radiation alone approach. The data supporting that here show that following an R1 resection with adequate radiation dosing, the local control ranges between 80 to 85%, which is around 10 to 15% lower than what we would have expect had the patient undergone a combined modality local control strategy. But that was okay with this patient. She was okay with a lower local control rate to try to avoid an additional surgery and only use radiation as the local control modality here following that unplanned excision. So this is the radiation plan. She had a positive margin, so the goal dose was 66 gray. It was again delivered kind of using a volumetric modulated arc therapy approach with an integrated boost, using several dose levels of 66 gray to the tight margin on where the tumor was, 60 gray to a larger margin, and 54 gray to an even larger margin. Again, trying to mimic that 3D conventional approach of 50 gray followed by a cone down to 60 gray, followed by an additional cone down to 66 gray in that positive margin patient. Taking us back to that first vignette, the 33-year-old gentleman who had an extraskeletal Ewing sarcoma following an unplanned R1-2 piecemeal excision with likely seeding of the anal canal. There was a lot of discussion about this case. What are the implications of that potential seeding? What are his surgical options now? What do you even take out? What are the surgical salvage options, likely requiring an APR if he were to recur, particularly in that anal canal space? What were the radiation-related toxicities now versus later? And what is the option of observation? Taking all that into account, as well as the radiosensitive biology of Ewing sarcoma, the prognosis of Ewing's, and what the implications are of a relapse, and thinking about surgery, we opted again for a radiation alone approach in this patient, with again taking the dose given the positive margin resection to 63 gray. Slightly lower than the last case. This is Ewing sarcoma. So theoretically, we can use a slightly lower dose after a positive margin resection, and also trying to do a little bit of thinking about how to spare him some of the toxicities related to radiation, given the location, related to erectile dysfunction, fertility, as well as the implications in his bowel function in the long term. And my last vignette, this is a 24-year-old male who presented with a 2-centimeter mass in the posterior proximal thigh. He underwent excision and pathology revealed a high-grade fibrosarcoma-like tumor, NTRK rearranged, measuring 3.2 centimeters, involving the dermis and subcutis with diffusely positive margins. This was one where there was a difference of opinion. So the patient saw both myself as well as the surgical oncologist. I thought that this excisional bed looked relatively well contained. This was a small superficial tumor in a young patient. I thought that this might be a case where we could consider just wide local excision alone without the use of radiation. And the surgical oncologist's opinion was different. They were concerned about the wispy nature of the operative bed, the fascial, the involvement at the fascial level, as well as the excisional scar was in the transverse plane, so that would require a slightly larger resection. And if I didn't do radiation, that the surgery would be even larger. So with a little bit of give and take, we opted to do preoperative radiation therapy in this patient, followed by re-resection. I treated him in the prone position using electrons to harness that charged particle so that we had a quick dose fall off and reduced scatter to his uninvolved tissue. And I treated him using a moderately hypofractionated course of 42.75 in 15 fractions. And that just brings me, I just want to highlight our approach at MD Anderson based on these data. So as you all probably saw, this was a recently published single arm phase 2 non-randomized study looking at moderately hypofractionated radiation therapy. So the standard typically has been 5 weeks of radiation preoperatively. This dropped the dose down to 3 weeks at 42.75 gray. The primary endpoint was major wound complications within 120 days, which was defined similarly to the NCI Canadian O'Sullivan trial. And it was monitored using a Bayesian time to event stopping rule using a historical comparison of 35%. There were 120 patients enrolled. The median tumor size was 7.6 centimeters. The most common histology was UPS, and 43% of the patients enrolled on this study underwent that OOP surgery or that unplanned excision prior to presenting to MD Anderson for treatment. About 50% received VMAT, 50% received 3D-based radiation therapy, and 30% of patients received neoadjuvant chemotherapy. The median follow-up was 24 months. The major wound complication rate was 31% at a median time of 37 days, with a crude local control rate of 95% and a 30-month local control rate of 93%. Treatment was well tolerated. So, based on these data of moderately hypofractionated radiation, this seems safe and effective, and this has really impacted how we are treating patients now. We've transitioned away from conventionally fractionated radiation therapy and have started using this moderately hypofractionated course. Unfortunately, I don't have time to go into detail about all the other schemas that are currently being studied, but this has become more or less our standard preoperative radiation course. So bringing it back, after an unplanned R1 excision, if surgery is planned, I think preoperative radiation therapy it should be recommended. These patients have an increased risk of local relapse and likely benefit from that local control benefit of the additional use of radiation. If no surgery is planned, there should at least be some discussion for the consideration of postoperative radiation, taking into account disease biology, the morbidity of surgery now versus later, radiation-related toxicity, and patient preference. So in conclusion, as we've discussed today, and as we all know, management of these unplanned excisions is complicated. The role of radiation really does depend on a lot of factors, but radiation should be considered as part of the management of these patients. And as always, a thorough discussion with the multidisciplinary team is really important and critical, and taking that information back to the patient so they can make an informed decision is really important. So thank you for allowing me to give a little perspective as to how the radiation oncologist thinks about the management of these complex cases.
Thank you. Thank you very much for this very clear presentation. And thanks to all the three speakers to have reviewed a very complex topic. So we start with one question from the audience, and maybe before having a roundtable discussion on our topic with all the panelists to address the question raised by the symposium, maybe a question to Francois, to Tomoki, and to Andrew. How many weeks do you wait to do the control MRI after surgery to define that you don't have residual disease? A question from Dr. Murcia.
Yeah.
Francois?
Okay, thank you. Generally, as soon as possible. It means that when the patient's referred, generally 2-3 months after the first operation, immediately we ask for an MRI. So as soon as possible, and in fact, it's generally never before the second or third month after the primary surgery.
Is it the same for you, Professor Nakamura?
It depends on the timing of the referral. So in Japan, it's not so difficult to do the MRI. So we can take an MRI within 1 or 2 weeks after the visiting the hospital. So maybe 1 or 2 months after a plastic excision, it's a very average time to take MRI.
Thank you very much. Andrew?
Yeah, I would agree. Similarly to Francois's comments, our approach is very similar.
All right. So while we are waiting for questions from the audience, I would like to maybe ask the question to all panelists. What would you do? What would you do in the case of R0 or R1 resection performed outside the reference center? And what would be your general strategy? Maybe starting on the screen with Manish. I don't know if you want to take this question, Manish, for what would be your strategy?
Yeah, sure.
What would be your usual strategy?
Well, I think what we do is a mixture of what all the speakers said. I think we look at what is the histology, something which is low grade, and suppose we have the previous imaging and we know that everything has been excised, then we can just give radiation. But most of the time we don't have previous imaging, like everybody said, there's an ultrasound done and then a surgery done and then there is no previous imaging. So often we look at clues from the pathology report. And if we find that the size which was reported on ultrasound is the same as the size which the pathologist has reported, and it's in one piece rather than in multiple pieces submitted for pathology, then I think we know that it has been more or less grossly, completely removed. But most of the times, again, it has been in multiple pieces, and we don't have clear-cut opinion from the pathologist about margins, in which case, then if I'm in doubt, I would clearly go ahead and do a re-excision. We have started using preoperative radiation now, particularly where contamination has been big and wide, because we really don't know, as the Professor Nakamura said, that it's so difficult to assess how much to remove following a previous excision. And even after removing a lot, we are still not certain whether we have removed everything, and we've still seen recurrences. So I think we give preoperative radiation that gives us a little more time to allow the inflammation to go away and then to reassess the margins and then excise.
Thank you very much. I think a balanced decision is the answer then. Javier, would you like to comment on what is your general strategy as a physician and maybe within your group as well?
Sure. Yeah, sometimes it's a tough task to try to compilate the information of one unplanned decision taken outside the center, because sometimes it's difficult to speak with the surgeon that has been in charge of this surgery. But in general, the MDT discussion of this case implies several factors. If the patient underwent or not to previous MRI or not, because sometimes the unplanned excision is taken just with ultrasound exploration, and then to discuss about the histological subtype and the grade. There are many options, as you can imagine. Grade 1 well-differentiated liposarcoma, for instance, maybe it's the decision is just follow up, because if no macroscopic residual tumor is left, then the option of follow-up is maybe the best option for our committee. But depends on the several options. We are trying as a general strategy to mimic the planned excision to this unplanned excision. Obviously with the re-excision for most cases, but if the tumor is a high grade, larger than 5 centimeters, and deep tumors, maybe the most frequent strategies to combine chemoradiation therapy and then the resection. We have learned in the Italian sarcoma group and Spanish sarcoma group, when we compare the randomized trial 3 versus 5 cycles in high risk localized soft tissue sarcoma, then when the radiation therapy was done in the concurrent phase in neoadjuvant setting, the deleterious effect of R1 scission was diluted, so was not a worse prognosis for survival after 5 years. So this is another advantage to consider the chemoradiation therapy, especially in high-risk localized disease.
Thank you very much, Javier. It's true that we have not spoken of the use of chemotherapy, and you rightly pointed out that this was something to be integrated. Jay, would you like to comment? What would be your strategy? Of course, it's not an easy question.
Yeah.
R0 and R1.
Yeah, there's so many comments. I wanted to just say, so that the case that that Andrew showed, the R1 resection in the ankle, is just a very poignant point, because there's almost nothing to re-excise after that. There's basically periosteum, maybe there's bone, there's no soft tissue. And, in the past, even though a lot of people might have said, oh, as a de facto, you need pre-op radiation and a resection and a flap, it may not really add much. And, that's probably a great case where just doing radiation is very reasonable. And, some people might even say, or wait. But surgery, there are cases where surgery is just not doable. You just cannot achieve anything better. There's some cases also where contamination is so bad that you cannot resolve that, and probably you have to just wait and see where the recurrence is, and then you'll know if there's a definable thing versus an amputation. It's hard to imagine, saying you just need an amputation for an R1 resection ever without sort of a time to wait. So that was just, I think, just a really sort of poignant point. The issue about MRIs, when to do an MRI, well, it's so variable when people are referred. Sometimes I get a call a week after somebody does an operation for something they thought was benign, and they're like, oh my God, I didn't realize it was a sarcoma. And then sometimes you get a referral 6 months later till the pathology ever gets sorted out, or somehow the patient finds out. So, I think most people just do the MR when the patient comes, and then you have to decide from there, are you going to watch and wait? It depends on all of these different factors that I think Andrew sort of talked about. A couple of things I just wanted to maybe say, there's a lot of people talked about residual disease and how common or uncommon is that. When we did one of our first studies, I was just looking back, like in '96, I was in JBJS, it was 35% residual disease by pathology. And when we just did this other paper that Francis had in his slide deck, was by Frank Traub, who was our fellow, and it looked at just stage 3 sarcomas. Like, it looked at people who had definitive surgery in our place versus unplanned excisions. So 20% of the 500 had unplanned excisions, and the residual disease was 83%. So when you talk about the potential of waiting and watching, you really have to think about who you're doing that in. And I think that might be feasible in kind of lower grade small tumors, because for those people, their risk of getting metastatic disease is like, it's close to 0. So what's the big deal? If there's a lot of disease morbidity to re-excising them or radiating them, so wait. But for high grade deep tumors, the thought of not doing something definitive when there's like almost a 90% chance that there's residual disease is really pretty poor. And in our study, and I think you showed other studies, Francois, too, and so did Tomoki, where if people did re-excisions, the results oncologically are pretty good. They're almost equivalent. So in a good center with multidisciplinary care, it's almost a bad message. Like, I think we were a bit concerned when we published this paper, because it almost says, if you screw up a stage 3 sarcoma in the community and send it to us, we can solve it. We can give you the same local recurrence and disease-free rate. And in fact, although you need more flaps and maybe there's a few more amputations, overall, the function's even pretty good. So, we can pat ourselves on the back and say, well, we're really good. But in fact, that message to the community is actually really bad, because it just tells people, oh, I can do what I want and they'll just solve it. But that's a different issue, right? So I think a lot of these papers that show that kind of high residual disease rate, and I think the initial papers that Francois showed, that looked at these small groups where people had unplanned surgery and some were just followed, the results, or the oncologic results, are significantly worse. So I think that when you're planning, if you're thinking of this idea of like not operating on people after unplanned excision, you just have to really think about the biology of those diseases. Now, I just saw a patient who was like 80, had an unplanned excision of a high-grade superficial sarcoma, and he's old and he has diabetes and he's not that well. And I'm sure anything that we did for him surgically would be a complete disaster from complications and from his functional quality life point of view. And listen, the guy's 83 and has heart disease and diabetes. Like, he's more likely to die from something else as much as he is from a sarcoma. And I think he and his son were happy when I said, we should just do some radiation and that's it. And in fact, the guy said, I don't want 6 weeks of daily radiation, so I have no interest in that. I'll come back if a lump comes back. And that's fine. You know, maybe that's okay. So I think those are some of the considerations, especially in this era of trying to figure out who doesn't need re-excision. And the last thing about that is, there's a lot of people where if you propose to them not to re-excise their tumor, they're going to be, they will not accept that, right? Like, there's a lot of anxiety when people have cancer and they know that they haven't had definitive treatment. And when you propose the watch and wait thing, some people might be okay with that, but a lot of people will say, I'm not very happy with that. I've been told I need surgery. And you can explain to them all the reasons why this randomization will be helpful, but a lot of people just won't accept that. I mean, we even know with lipomatous tumors, ALTs, some people, when you say that you're not reoperating on them, or that you're not going to operate on them in general, they're just, you know, they just cannot accept that. And I think it's even more so with this. So that's another sort of consideration, not just about the morbidity of retreatment, but people's considerations of having a potential time bomb sitting in them. Yeah.
Thank you, Jay. I think you rightly pointed out on the difficulty of further studying in randomized settings this question, and this is an equation with many unknowns. Gabriela, would you like to comment on top of what has been said already? What would be your strategy? What is your strategy?
Thank you. So first of all, thanks to all speakers, great talks, really interesting. Regarding Andrew's talk, listening to your talk, I think it's as you would describe our approach in detail. So very low threshold to perform pre-operation in the R1 situation. We're also working with hypofractionation, so it's not such a bad thing for patients. It's not 5 to 7 weeks, it's just a couple of weeks. And another point not approached so far, I think when you work with radiophobic surgeons, it's getting somewhat difficult. When you work with guys like Bruno or Jay, it's kind of fun. So they appreciate radiation. It's not a fight all the time. I think that's a point we have also to address. So the fear of the radiation side effects. So, yeah.
Bruno, what do you think? You're the next on the screen. What would you do?
Well, you know, Gabi and Beata, basically we are a team, and I only agree with what Gabi said, and I'm sure Beata has also her thoughts. I mean, I think, you know, the unplanned excisions and, let's say, the standardized R1 resections, I think maybe we even have to distinguish those from the unplanned excisions. And I think that opens also another issue, right? I think, you know, it would be also interesting what Gabi alluded to, the type of radiation. Andrew pointed out the hyperfractionation. Of course, I would be interested what he thinks about ultra hypofractionation, but we will have a webinar in summer on that. And but I think I also want to highlight maybe the path view. Maybe Beata, you wanna address this before we then go to the light in Vienna and Rizzoli.
Well, I think it's very interesting. Thank you for your comments and for the great talks. That you all appreciate the role of the subtype of the sarcoma. It's so important, you know. It's not the all sarcomas are the same disease. So actually, when this case with Ewing sarcoma, superficial and small one, was presented. So I think it would be even difficult to decide to discuss what to do if it were not a planned excision, because it's such a complicated story with Ewing sarcoma, small superficial. So this is so important, and we always get this unplanned resections, this whoops thing, and sometimes it's in one piece, sometimes it's in plenty of pieces, and it's so difficult, kind of to confirm to somebody, okay, it was totally because the centimeters added together. So it's I'm really positively kind of well, not surprised, but I think it's so important that you all guys, not pathologists, also know that what the personalization in sarcoma means concerning the sarcoma subtype as a disease of itself.
Thank you very much, Beata, and thank you very much, Gabriel, as well. Michelle, what would be your strategy? A lot has been said, but I'm curious of what would you do for IR1 resection?
Yeah, I'm not going to echo everybody, but I'm going to appreciate what's been said, and it's been a very interesting couple of talks. I think I just want to underline that trying to appreciate the risk of local recurrence for the individual patient with the individual tumor and location, as Jay pointed out, would be very helpful to know whether, one, the tumor will come back, and two, what the influence of this recurrence will be on the survival. So this will make probably for us to decide to do resection, if resection would be feasible, or just radiate, or just wait and see. So I think trying to assess best as possible what the treatment that has been given, how that influences the risk of local recurrence by any kind of prediction model would be super helpful. So that's what we would do in our unit, would try and use our model and see what the additional treatments of chemo, radiation, or re-resection would do on the risks for local recurrence and overall survival. So I think that's just what I wanted to add, and thank everybody for their great talks and comments.
Hey, Jean-Yves, can I just say one thing? One really important thing, and I think for all of us, we talk about this, is it's not always clear if somebody's had an R1 or an R2 resection. I mean, if you find the original pathology report and they say there's multiple pieces of tumor, it sways you one way. When you have somebody who comes with an excisional biopsy, there wasn't maybe imaging before, and you think that they've had an R1 resection, the problem is a lot of those aren't. Yeah. And it's amazing how often after an R1 resection, or what you think is an R1 resection, where the patient, you thought it was you're trying to figure out how good or bad did the surgeon do a job. It's often amazing how often they show up in your clinic the first time and there's already a gross local recurrence, and you think, how could that be if it was just microscopic disease left behind? But that's one of the problems with all of this is, we're trying to retrospectively put people into this category of it was an okay resection or it was a terrible resection, and you often can't. And that's sort of another problem that gets back to this whole idea of individual patient risk. And again, lower grade, smaller tumors it's probably, you can almost take them out of the equation. It's a bit less of an issue because it's not such an issue if they recur in terms of their metastatic risk. But for everybody else, there are bigger risks at play. And I think, again, those first couple of papers that showed the differences, the worse outcomes in patients who had just follow-up as opposed to re-excision, are very poignant papers in terms of kind of our decision making for that individual patient. Yeah.
Thank you, Jay. I think that's very important. I think we are converging clearly. Philip, would you have comments? What would be your strategy?
Yeah, thank you. We in Vienna, I think we still follow a very aggressive strategy towards re-resection after unplanned excision. Basically, very lot based on our results, especially on what already has been pointed out and so clearly presented in those excellent talks today. But also what Jay said, that there is a large amount of patients who are remaining with residual disease and probably more than we initially expect. And also our own paper has shown that we are completely unable to detect any clinical predictors to decide between patients who are more likely to have residual disease versus patients who are unlikely to have residual disease. So we might end up in regarding anybody as having residual disease, therefore clearly indicating re-resection. And again, I have learned a lot today, and at the same time, I'm left behind with many questions, because with the increasing data we have on especially those favorable anatomical sites, the superficial smaller tumors, where we now have the ongoing discussion, are we following a wait and see strategy versus an one resection? It reminds me a lot of the discussion that we are having with the biopsy tract seeding. And I remember a discussion with Robert Turcott where he would just throw up the question, why would I leave behind this tiny biopsy tract that is so easy to include in my resection, that does not go along with any morbidity in the surgery? So here I have the same question to the whole panel. Why would I consider a wait and see strategy in a tumor that is so easy to re-resect and has not a lot of morbidity, and maybe would just leave the patient behind with a larger scar due to a skin transplant? The cases, in my experience, I'm really struggling with are those deep cases close to vessels, close to nerves, where we have to decide, do we really gain some advantage in excising the nerve and doing a segmental reconstruction of the vessels that have or have not been affected during the first surgery, because we never can really answer those questions. So I think there's a lot, we need a lot to know about those deep and ugly and nasty tumors in the really hard to treat anatomical sites.
Thank you very much. Costantino, the view from Rizzoli.
I don't want to talk. I don't have the answer. I'm waiting the prospective study by Nakamura to have the answer. I mean, I just can say that in Rizzoli in the past we were more aggressive, so we made surgery in all patients who underwent unplanned excision. So far we are less aggressive, so I agree with Philippe, Jay, Wunder. If we have a low-grade tumor or superficial small tumor, local recurrence does not impact the survival, so we can wait and see, and it's just only 50% of patients can have a local recurrence. We can avoid radiation and surgery for the other 50% of patients. So I can say just that we are less aggressive right now, and as you said before, it is important to know the biology of the tumor, so the grade, if it was superficial, small, or deep, and so I'm waiting the prospective study by Nakamura.
Thank you very much, Costantino. And that gives actually a good link to the next question. Shintaro, a discussion on randomized study. I was impressed actually by the fact that the control arm, as a standard arm in the randomized study, was re-excision actually. And that's something which is interesting. That's a position of the Japanese sarcoma group together with Professor Nakamura.
Yeah, thank you very much. So today, we have a very good presentation for everybody for the special specialist. So I have learned a lot from every specialist, and also, but ultimately, so the prospective trial must be mandatory to clarify the problem. I just added the one statement from the another view from the another view from the view that so we planned such kind of randomized trial, and we have a good chance to talk with the patient group. So patient group of the sarcoma. So we present the Dr. Nakamura's idea. So randomized trial for the after the OOPS procedure, do the additional resection or wait and see. So we scientists all agree with that idea, but the patient group strongly against to participate this idea, because they cannot stand for just wait and see after the OOPS procedure. So this is also very interesting point of view. So that we have to consider so how to explain for the patient for such kind of randomized trial, but we should better to try. We have to think about to solve the problem.
Thank you very much. I think the question of randomization, I think it was Jay who mentioned that it could be hardly acceptable for some patient. So you go in the same direction. Actually, that is a reminder probably of a very important study for disease group, which was a link study for osteosarcoma some 30 years ago. Where actually the patient were randomized chemo, no chemo, but the patient could also select the option, and they were published in parallel, and the survival of patients reoperated, treated with chemo was similar in whether they were randomized or not. Probably one strategy could be also to follow the patient who refused randomization and select one of the two options. Maybe I think, is it fair to say that everybody agrees that we have reached the limit of the retrospective study, even though they can be very large, and that probably the next step is going to be a prospective study, maybe randomized if feasible, if not carefully designed in order to be able to collect information so that we can conclude on this question. And in this case, maybe a question to all of you. What is the control arm? Is it re-excision or is it watch and wait?
While we weigh the utility of a prospective study, I mean, I think that's certainly an important concept, and I think our patient population would struggle a little bit with the idea of randomization. But I would propose that maybe as we think about what the arm should be, we do want to think about how we should incorporate radiation into the paradigm. Obviously, stratifying by grade and histology and other factors, but maybe the arms should be watch and wait versus preoperative radiation and surgery versus radiation alone, because there are a subset of patients where we might be able to not do re-resection and consider a radiation alone approach. So that might be something to think about as we weigh the pros and cons of that type of prospective study.
An interesting suggestion. Thank you very much, Andrew. Other comments? Francois, what is your standard arm?
That's a question. Yes, I think that if we want to conduct a prospective study with a control arm, we have no choice of a subgroup of control. We have to choose a group in which a re-excision is no morbid and easy to do. I mean, it's impossible to randomize patients with unplanned resection along the vessels or nerve, as Philippe say. It's very difficult to randomize in the arm of segmental resection of the vessel, something like this. We have to select a subgroup to include patients, for example, intramuscular unplanned tumor of somewhere not too morbid re-excision. That's the only way, in my spirit, to go now.
Thank you, Francois. The selection of patients is going to be critical in this study, whatever it is. Any other comments you would like to bring to this discussion? And I take this opportunity also to propose to our hosts or viewers, would you have any further question? There was one question, I think Michel answered to this question, which was, how do we avoid basically to have patients operated outside reference center? And I think in countries like the Netherlands, UK, Nordic countries, possibly Canada, possibly Japan, I don't know, but certainly not in all countries, a good organization is probably the mandatory referral to a reference center, maybe by organizing the reimbursement only if the patient has been treated in a reference center. We are not there yet in some countries, including ours with Francois, so that's sad, but that's probably the best way to do it. We are close to the 6:30. Maybe I'll try to have a summary of what has been said. The first thing maybe is to thank again all the speakers for the excellent quality of the data. We have seen that there is a large amount of data which go in a direction which is relatively clear in the face of R1 resection, which was completely unplanned. Re-excision brings something. To which extent does it is it feasible always? To which extent is it wished or not by the patient? To which extent is it useful in terms of long-term survival is something which is obviously debate. Actually, we are facing an equation with multiple unknowns. The unknowns are histological subtypes, of course, the grade, of course, the site, of course, the margins. Is it a true R1 or a false R1, which is actually R2, as it has been discussed? The associated condition, diabetes, old age of the patient, associated medications, is going to, it's at least an equation with 7 or more unknown. And one major unknown is actually the wish of the patient. Because you discuss at the end of the day with the patient who may want or not want to get re-excised, whatever the risk is. And we have heard that for some tumor types, high grade and resection, the risk of a residual disease is close to 90%. So it's basically a biopsy which was done before that. So we need definitely a randomized study. And I think the example provided by our Japanese colleagues is very much encouraging. And I don't know whether it should be a unique worldwide study or whether we should do studies in all countries and then put them together in a meta-analysis. But I think we need to explore that question very carefully, taking into consideration the patient opinion. That's going to be very important as well. Thank you very much, Bruno, and thank you very much for all the team for organizing this discussion. I think we could have stayed for probably 2 additional hours to discuss all the options. Thank you very much.
Well, Jean-Yves, I have to thank you, and of course also the presenters. I just loved it. It's just a fantastic webinar that we had. We all learned, and of course, if we are being left with more questions, the better there is. So feel free to continue the discussion. Also for the future webinars.